and your web browser, I think you will still manage to survive. But ideally, try to see if you can join on your phone and maybe use your laptop to join the Stanford database. But yeah, I think Dr. Leon will give guidance on that. If you are joining us for the first time, this is the clinical care platform, and we exist to improve patient care. We hope that these resources that we share most evenings of the week, really translate to you becoming a better version of yourself, but importantly, where you are able to maintain your competence as a health professional. Today's event is actually accredited for at least 2 clinical points. You must have seen that we will not finish anytime before 20 hours. So be patient, but also appreciate that you will get at least 2 clinical points. And yes, continue to celebrate with us an incredible milestone of over 50,000 CPD credentials that have been issued to yourselves, our members, and those who continue to support. If you're not a member, do visit our website. If you have a personal mission to become a great clinician and you see that we can help you to get there, join us so that we can continue to support you. We have a very interesting in-person event coming up in October on the Fine Needle Aspiration Boot Camp. So if you are interested, I will share links later on, and then just register your interest. For now, we just want to see how many people are interested so that we can pursue it. And next week, Saturday, we have the Mechanical Ventilation Masterclass. If you are still overwhelmed by all the knobs on the ventilator machine, maybe you need to join us on Saturday. We promise you that we will leave you very confident to deal with these machines. And yes, just to wish everyone who's going to be writing the HIV diploma exams in the next week or two, all the success. And if you are planning to write in 2025, stay put. We will announce the next intake for the preparatory program around September or so. But for tonight, it's we welcome back, Dr. Leon. He belongs here at Clinical Care Platform. I won't say a lot except that he's got wealth of experience, and today he's going to take us through one of the topics that can be overwhelming. It can seem very complex, but I'm very positive that after today, you would also leave today's session being very confident and be in a very good position to continue to manage your patients going forward. Dr. Leon, a warm welcome. I don't want to delay the colleagues because I know that they are looking forward to this particular session. May I hand over back to you? Can I share from my side, or you are reading from that
No,
side?
I can share from my side. It's just disabled. If you can just enable it, and I can share.
Okay.
Thanks.
Super. I
Yeah,
was
we seem
ready.
to have sorted out. Yeah, we had some technical issues, but they seem to have been sorted.
Thank you, Doc.
Okay, just still said it's disabled.
Can I just, you do
It
have
looks
the
like it's working.
co-host, right?
Yeah, it looks like it's working now.
Okay, yeah.
All right, are you seeing my screen?
Yes, it's coming
It's not presentation mode yet.
It just says, okay, yeah. I think now, colleagues, you are able to see the slides, right? The thumbs up will
I'll
do.
give you a
Thank
quick
you.
preview of what this talks about. Okay, cool.
Yes.
I just need to say one thing more I need to do. I just need to quickly just get the links.
To share. Okay. Yeah.
Yeah,
If you
how do
share,
I get out
I'll
of
keep resharing.
yeah. I just want to just how to get out of this I'm going to stop sharing to just copy those links. Give me 2 seconds. It's right here.
Okay, colleagues, there's links we need to share with you, which you will use.
Okay, I've got them.
Practice.
Right.
Yeah.
Okay, I'll start talking. Okay. Well, thank you very much, Lesego. I apologize for the slightly delayed start because of the technical issues, but we seem to have resolved them now. So as we mentioned last time, it's sort of like a series of talks. Basically, we used to have a resistance workshop, which was like a 1 day, and then we did it over a couple of evenings, but it was like 3-4 hours in the evening. It was quite heavy. And now we've sort of split it, and not quite the same thing, but almost the same thing, doing it one talk in the evening. So one of the talks would be, there's two of them actually. One would be where we've got a virologist to discuss the mutations. And the other one would be where I would then use those mutations to show you how to use the Stanford database. Okay, so I'm not a virologist, and I've permission from a virologist to use some of their slides. So we've condensed it into one talk. So I have put on the links there, and Lesego will keep on sharing. So the one that you want for later on, for halfway through, is going to be the one that says Stanford database. That's the one you'll click on when we get to that point. You can click on now if you've got another device to get yourself ready, but we don't need it just now, but just for halfway through, I'll tell you when. Okay, Lesego, so for the benefit of new people who are joining, you can maybe keep on re-pasting those links in the chat. Okay, so those are my disclosures. Thanks once again to AbbVie for sponsoring this presentation, and to thank our virologist, Dr. Carol Wallace and Dr. Viana, for the use of some of their slides. That's the link which I've shared, so you can click on it already or just use it later on. Okay, so just a quick talk about the resistance tests that we have. We always say you set up a resistance test, but we don't really think about what test we're ordering. There's two kinds of resistance tests. One is not available in this country. That's why we don't think what we're ordering, because whatever you can only get the one. Okay, so the one is a phenotypic test. Now that is the virological equivalent of what? Of an MCNS. Okay, you do a throat swab, you send it to the laboratory, they culture it with some antibiotics, and come up and say, okay, well, this antibiotic works, this one doesn't work. Right, that's your MCNS, microscopy, MC, culture and sensitivity. Right. Okay, so with a phenotypic test, it's not exactly the same, because they don't take the whole virus and culture it. They take bits of the virus and they culture it, but it gives you a very similar kind of thing. It tells you, if that antiretroviral drug will work against this virus or not. Now, that's a very expensive test, very time consuming. The last I checked was something like $2,000 a test. Okay, even with the rand being pretty good, that's a lot of money. And so it's not done. Some research facilities, people doing clinical trials may use it, but otherwise it's generally not used. So what we use is the genotyping test, or the genotypic assay. And that's where they look at the actual, they sequence the genes, they look at the actual, you can see which genes are there, and based on which genes are there, they will then say how much resistance there is. And often what's been done previously is that they've compared the genotyping with the phenotyping, so they know based on what genes we're getting, what you would expect with the phenotyping test. Now, the normal test that we have available is population-based, where we'll only pick up, we say, 25 to 35% of the population. If it's below that amount, it will not be picked up. There are other tests which are called minority variant assays, which will pick up less than 25%, but they're not really used maybe in research only. Okay, so the main one that we use is the genotyping test. We're looking at the genes, and the population-based one, where we're looking at above 25% of a population of 25 to 35. Okay, before we go on to anything else, I need to let you know about the mutation notation. Now, I usually do a poll, and I'm sorry, I forgot to do this poll. So maybe if I could just have hands up, are there any virologists, or just send me a thumbs up. Are there any virologists in the audience? Any virologists, please send us a thumbs up. Great. Great. Okay. I'm very pleased there's no virologist. I hope you're not a virologist. Okay. I'm very pleased there's no virologists in the audience. Why? Because you can see what it looks like. It looks like a secret code. Can you see? Look, M184V. Well, what is that? A secret code. That's exactly right. It's a secret code devised by the virologists to make sure we didn't know what was going on. That's why I had to make sure there were no virologists in the audience. I'm going to break the code. I'm going to tell you what it means. Okay. But please don't tell the virologist that I told you. Okay. So this is, you'll see, it's typically you'll have a number. Oh, I saw thumbs up. I hope it's not a virologist. Okay, another one. Okay, number in the middle, letter on each side. So what do they mean? So the number in the middle, that's quite easy. That is the address. That tells you where you will find the mistake. Remember we said mutations are mistakes the virus makes. And so this is where you'll find the mistake. So in this case, at position 184, the viruses have got a numbering system for reverse transcriptase, protease, integrase, and as we get more new drugs, they'll have for the other drugs as well. Okay, so this is going to be reverse transcriptase. Position 184, this is where you're going to find this mutation, this mistake, right? What is the number on the left? The letter on the left. In this case, an M. What does that mean? It means what amino acid do you find at position 184 in wild type virus? Remember we spoke about wild type, the naturally occurring virus. So in wild type virus, you're going to get a position, at position 184, there should be an M, stands for methionine. And each of the amino acids have got a code for us to understand, which one it is. But at position 184, in wild type virus, you're supposed to find methionine, an M. Okay. What's the letter on the right? The V. That tells you what's there instead. That's the mutation. And at position 184, instead of a methionine, there is a valine. Okay, this virus made a mistake. Instead of saying, where's methionine? Grabs a methionine, sit on, but it's not a methionine, so a valine made a mistake. And now this virus at position 184 has got a valine instead of a methionine. Okay, so that is what this mutation notation is. 184V means at position 184, instead of a methionine, is a V, a valine. And this is the classic 3TC resistance and FTC, 3TC and FTC resistance mutation. Now, letter on the left, the image is always the same. Why? Because it's wild type. At position 184, it's always going to be M. So for those of us, it's a mouthful, that 184V, you can leave out the first letter. Because we all know position 184, it's always an M. So you can just say 184V. So you'll see when I do the Stanford database, when people phone me about a third line case, we want to see, can we simplify the regimen? Then I say, don't have to read M184V, just say 184V. Okay? Because at 184, we know it's always going to be an M. Is the methionine will always be in wild type virus, but what we need to know is what is there instead. So we need to know what's on the right. So the V would be the important one. But the M is not so important. You just say 184V. Okay. So that's a mutation notation. Now, what happens if you see something like this? 184MV. That is such a mouthful, right? What does that mean? So let's analyze it. Position 184. The letter on the left, the M, methionine, is what should be there. And the right is what's there instead. But now what's there? There's both an M and a V. Oh, what's going on now? This we call a mixture of wild type and resistant virus. Okay, so there's a wild type virus floating around with methionine in position 184, and there's some resistant viruses with a valine in position 184. So that's what this M184V MV means. What does it mean in real life? What's the significance of it? So if you get 1 or 2, it doesn't mean anything. Okay. And so we treat it as if it's a mutation. So if you see this, we say, well, the valine is there, so there's resistance, even though there are some viruses that don't have the resistance because it's a mixture. So you treat it as if it was a mutation. Okay. But if there are many mixtures, so there's 1 or 2, not a problem, we just ignore it. If there are many, more than 5, more than or equal to 5, it could point to 2 things. Number 1, a lab problem, and number 2, adherence issues. Okay, now more than 5 mixtures is a WHO red flag for the laboratories, which means if the lab picks up more than 5 mixtures, they are going to investigate and make sure that there are no problems with their system. So by the time it gets out to you, if there's more than 5 mixtures, you know it's an adherence issue. So what's adherence issue? Okay. Well, let's take a patient who is not taking the treatment at all. They're not taking the treatment at all. So which virus is going to be there? We discussed this last time. Wild type virus, right? So there's lots of wild type virus. Resistant viruses are hiding away. It's archived. Right. Now, Dr. Leon says, we're going to do this test in a month's time, but it'll only be accurate if you take every dose for the next month. Okay, so the patient listens to me, surprisingly, and takes every dose. Now they suppress the wild type virus, the resistant virus comes up, but the wild type virus hasn't quite disappeared, and the resistant virus hasn't quite become dominant. So you've got a mixture of both. So they went from all wild type, no resistant, to half-half. Okay, if we waited longer, they would have obviously suppressed their viral load, or they would have had fully resistant virus, and the wild type virus would have disappeared. But because we did it at a month, we got it when there was a bit of both. So if you're seeing more than 5 mixtures, and we saw one patient last week at our advanced clinic, I think had 8 mixtures, 8 different mixtures. And that clearly was a patient who either, in this case, was not taking the treatment and then suddenly started taking the treatment, or the reverse. They were taking the treatment and they stopped taking the treatment. So now wild type starts coming back, the resistant virus starts coming down, and so you get to a point where you get both of them there. So if you're seeing a mixture, it means they've either just started taking the treatment again or have just stopped taking the treatment recently. Okay, what about these resistance mutations? We said they can be specific to one ARV, but you can have cross-resistance to other ARVs that they've never even been on. We know 3TC and FTC, they're resistant to 3TC, they'll be resistant to FTC. Okay, we spoke about the TAMs, which we're going to talk about them now. Thymidine analog mutations. Okay, and those are mutations that cause resistance against AZT and the old D4T. So if a patient has been on D4T, well, you've got resistance, well, then AZT is not going to work. So because there's cross resistance between those mutations. Okay, now the strength of the resistance reaction can be very different. What we call viral fit can be affected. Some mutations can cause the virus to be very weak and replicate very slowly, right? Some mutations can be very strong and replicate very rapidly. Okay. How easy is it to get resistance? We spoke about this last time. Dependent on the ARVs. Remember, some have got a low genetic barrier to resistance. One mutation, like 3TC or efavirenz, nevirapine, raltegravir, one mutation, they can get resistance very easily, and within 2 to 4 weeks of non-adherence, very quickly. And others need many mutations, what we call a high genetic barrier to resistance, can take them, years to get resistance. So, as I said, how easy depends on the patient's adherence, a whole lot of other things, but also which drugs they're failing. And remember, if you keep them on the same failing regimen, you're going to get more and more resistant mutations, and resistance will get worse over time, as we will see later on tonight. Okay, so that's just a background on resistance. Please feel free to ask any questions. And I know that generally in this talk, not too many questions, okay? Because it's so the real reason is because I wouldn't be able to answer them. I'm not a virologist. But even if I could tell you one, but if you've got any questions, that you want to ask, just in general, in terms of patients failing, or you've got a case you want to discuss, feel free to put on as well. If we've got time, we can discuss it at the end. Okay, so now we're going to discuss mutations. This is a very simple, just for people, non-virologists. Okay, so let's talk about the common mutation that gives resistance to the NRTIs, nucleoside reverse transcriptase inhibitors. Let's start with our old friend, right? M184V or I. Okay. So 184I is if someone is starting to fail their 3TC, generally the first mutation they're going to get is 184I. Okay, and then that's replaced by 184V. But most of the patients you'll see don't have the 184I, they only have the 184V. And as we said, it's linked to 3TC and causes high level resistance against both those drugs, 3TC and FTC. But it also profoundly weakens the virus. The viral replication capacity is reduced. I'm going to show you that now. Real case of how it does that. What about the other drugs? So what it does is it makes the 3 other 3TC got activity of 1 full log, and in the patients who've got resistance to 3TC, this has got activity of a half a log, which is actually acceptable as an NRTI. So that is why we reuse 3TC, even though there's resistance, because it drops the viral load by half a log. Also, it partially reverses resistance to D4T, we don't use anymore, AZT and tenofovir, and also it weakens the virus and makes it easier for the other drugs to suppress the virus. Okay, so that's, people always ask, why do we reuse 3TC? Now you've got your answer. So the next mutation I want to talk about is a very famous mutation, K65R, or N. We see the R. And why do we see the R, not the N? Look at the asterisk at the bottom. K65R is much more likely to emerge in subtype C, which is what we have here. So we virtually don't see the N. We see K65R. Overseas, they have different subtypes. They may see the N as well. Now, K65R is your classic tenofovir mutation. It's caused by not only tenofovir, abacavir, the old DI, and D4T, which you don't use anymore, but they also can cause this mutation. And it causes resistance to all the NRTIs except AZT, which actually, incidentally, it makes it hypersusceptible. AZT more active. Remember that for later on, okay? But the K65R makes AZT hypersusceptible. But it also weakens the virus profoundly, and the K65N weakens more than the K65R. But K65R does still weaken the virus. It makes AZT work that's either hypersusceptible or will reduce AZT resistance. Okay, right. So that's the second one. The next one, L74V, is one for the pediatricians and the nephrologists. Okay, you can guess which drug we're talking about now. So this is L74V or I. Okay, we usually see mostly V, but you can see I occasionally. Linked to abacavir and causes resistance to abacavir. In terms of weakening the virus, L74V does, but L74I can, in certain situations, actually strengthen the virus. But it also, L74V or I, does make the AZT and tenofovir stronger. Okay, let's move on. 115F we see every now and again, fairly common. It's also linked to abacavir and TDF. Causes resistance to abacavir. All the other drugs will work except abacavir with a slight effect on tenofovir. Then this one, oh, this is the baddie. This is the mafia, the mafioso of resistant mutations. This causes what we call a pan NRTI resistance. There are three what we call, sorry, I've gone blank here, which cause 3 multi-NRTI resistance complexes, and this is one of them. Okay, I'll just mention the others. There's a Q151M complex. These are cause resistance against the entire class of NRTIs. There's Q151M, which is what we're talking about now, the mafioso. Then there is the TAMS, which we're going to talk about next. And what I'm not going to talk about is the 69 insertion, where you get a whole chunk of material inserted at position 69. So those 3 can, if you've got enough other mutations, wipe out the entire class of NRTIs. But let's talk about the mafioso. So who is the head honcho of the mafia? Is this Q151M. That's a primary mutation. Okay, and the other 4 are his honchos, are his assistants. They are the secondary mutations, right, at 62, 75, 77, and 116. And these we don't see much anymore. We used to see patients failing D4T, DDI for long periods of time. Okay, it starts with the primary mutation, the Q151M, and then the secondary mutations start. And as you get each secondary mutation, you're going to get more mutations until you've wiped out the entire class of all the NRTIs. We unfortunately don't see it much anymore, but it still is around, and there are patients who still got it from the old days who still have this mutation. All right, TAMS I spoke about earlier, right? TAMS is also a multi-NRTI complex that can potentially wipe out virtually the entire class of NRTIs. And these stands for thymidine analog mutations. So what are thymidine analogs? That's D4T and AZT. So to the virus, this looks like D4T or AZT, incorporates this drug into the chain, and that stops the development of the replication of the virus. Okay, so which are the TAMs? Now the TAMs are at position 41, 67, 70, 210, 215, and 219. You can see the mutations up there in the gray block. Okay. It's one kind of thing that when you get to a certain level, you actually need to memorize it. You know, I used to travel in the old days lots. I once had on a plane, put an article and just memorize. You know, I'm not looking at the screen, right? 41, 67, 70, 210, 215, 219. Okay, you just need to know the positions of those mutations. Okay. And now TAMs are very interesting because one TAM probably would do nothing. By the time you need 3 or more TAMs to cause resistance to AZT, and G40. If there's a 41 or 215, then you can get to novel resistance as well. Now, TAMs are very slow to develop. Okay, on average, you get 1 TAM for every 8 months that the patient is failing that regimen. So if a patient has got 3 TAMs, you know they've been on that regimen for at least 24, 2 years. So it is really a high genetic barrier to resistance because you need these 3 mutations before you can get resistance, and that can take you 2 years to get your 3 mutations. As I said, if you've got a 41 or 215 mutation, you will get resistance to tenofovir as well. Okay, and it affects all the NRTIs except 3TC, but most of these patients are on 3TC anyway, right? So they're going to have 1N4V, so the whole class of NRTIs will be gone. Okay, so that's the NRTI. So the important ones you need to know if you're writing exams or if you want to interpret it. There's not too many to know. The most important ones you need to know would be, let's go back quickly, would be the 1N4V, 65R, Q151 you don't need to know, TAMs, okay? And you should know the positions of the TAMs. So those are NRTIs. Now let's talk about the non-nucleosides. We don't use them much anymore, but they're still around, and a lot of patients who got these mutations. 103N, that is a very famous mutation, K103N, linked to efavirenz and nevirapine. So now this is a very interesting mutation. Why? Because unlike 1N4V and K65R, which weakens the virus, that's a car traveling 10 kilometers down the highway, K103N hardly weakens the virus. It's very strong. That's a car traveling 110 k's down the highway. So when you open up the gates and take them off their nevirapine or efavirenz, and you unleash wild-type virus, it takes a while to get to overtake this. And very often you'll find a patient who 10 years down the line, they've been off their non-nucleoside for 10 years, they've still got K103 in them. Why? Because it doesn't get weakened, doesn't weaken the virus. Okay, it's a very strong virus, and so it's hard for a wild type to overtake it, and a wild type may never overtake it, so it may always be around. The second generation efavirenz and rilpivirine will work if you've got K103N. Y101C, similar, linked to nevirapine and efavirenz, but here the second generations will not work. So that's why the problems with efavirenz, sorry, with the etravirine and rilpivirine is that you can't predict whether it will work or not unless you've got a resistance test that tells you it will work or not. Okay, because they've got 103N, it will work. If they got 181C, it won't work. And the problem is that we don't do resistance testing after a non-nucleoside regimen. So we don't know which mutations they've got. So we don't know if efavirenz or rilpivirine will ever work. Okay, and I see Mervyn made a comment to that, say, overseas, they do resistance testing, after first line, second line, baseline as well. Baseline, first line, second line, third line. So there you do know which mutation, but we don't. Okay, so it's not the end of the world. Okay, but just to be aware, you can't always predict which of the second generation will work because we don't have resistance testing when they're on the non-nucleoside. While 188L is another one, very similar. Etravirine will still work in that situation. Q106M, this has got a very South African slant to it because it was research done in South Africa. Overseas, they have the V106A. We have V106M. So it's linked to subtype C, which is our subtype, but there was work done in South Africa as well in this mutation. And the second generation in non-nucleosides will work in this situation. Q190A is another one where the second generation non-nucleosides will work as well. Okay, so that's the non-nucleosides. So it's something that we don't worry too much about non-nucleosides anymore because we can generally predict what sort of resistance you're going to get after non-nucleoside regimen. We don't generally, the guidelines say not to do resistance testing after non-nucleoside. So we don't pay too much attention to non-nucleosides anymore, but we did in the old days. Okay, what about PR resistance? So here there are different kind of mutations. Some make a big change to the protease enzyme. That's what we call a major mutation. And some make a small change, which you would call a what? A minor mutation. Okay, we used to call them minor. Now they call them accessory mutations. But there's still some people that call them minor mutations. Okay, so you have major or minor mutations. You need to see, and that's what we generally say, which major mutation you have and which minor mutation. Okay, so depending on the PI, and because we are using a booster, you need more than one major mutations to give you a high resistance. So as we say, once again, the PIs have got a high genetic barrier to resistance. And these are all the common mutations. I'm not going to go through them all with you. Just to focus on darunavir, which is obviously where we spend a lot of our time talking about. So you can see the important ones in bold for darunavir would be the 32, so it's V32I, all right, the I50V, okay, I54L or M, and L76V and I84V. Those are going to be the darunavir. We'll come back to that. You don't have to memorize this at all, okay. So, but if we talk about, there are a whole lot of darunavir mutations, about 11 darunavir mutations, but these are the major mutations: 32I, 50V, 54L or M, 76V, and 84V. Those are the ones I showed you up there. Okay, and you need 3 major mutations and 2 accessory mutations. So it's got a very high genetic barrier to resistance, darunavir. Okay, much higher even than dolutegravir. In the Nadia trial, there were 9 patients who had developed resistance to dolutegravir, but 0 had resistance to darunavir. So the darunavir has got a very high genetic barrier to resistance. Okay. Right. Now, what about the integrase inhibitors? That's the flavor of the month, right? We're all talking about integrase inhibitors. So what resistance do we get to integrase inhibitors? So this is a bit complicated, but I'll put little rectangles around and make it easier. So in the old days, when we used rel, resistance very easily. And these are the 3 classic rel-tegravir mutations at position 180, 143, 148, and 155. Okay, of which 43 does not cause cross resistance to dolutegravir, but the other 2 do. So that's a problem. If someone's been on rel-tegravir, they could get cross resistance to dolutegravir. The classic dolutegravir resistance. So someone who's been on rel-tegravir, then goes to dolutegravir, they can get one of these mutations. But someone who's never been on rel-tegravir goes straight onto dolutegravir. The classic dolutegravir mutation is the 118R on the left, the 263K, and the 155H. So the 263K is the one that we knew about for many years. Okay, it was shown in vitro. The 118R is the one that is overtaken very rapidly because we're seeing more and more of it in the real world situation. And the 155 is common to both rel-tegravir and dolutegravir, but in patients naive to rel-tegravir, it's unusual to see the 155. Okay, I'm not going to go through the slide. Basically, it shows very similar, but just to go through what's at the bottom is that for a lot of the labs, we'll need to order a separate test integrate. Certainly NHLS, most of the private labs, but I saw one of the private labs is now saying they're doing it routinely together with protease inhibitors and reverse transcriptase. So that's the way I think to go. That you don't have to, but just check because certainly in NHLS you need to. That's one of the reasons why you need to fill in the form and say what regimen they're on, so they will test for. These 2 additional accessory mutations. Right, so this is just summarizing what I spoke to before. If we look at in the blue here, rel-tegravir on the right, you see that the 3 rel-tegravir mutations is going to be 148, that's the real baddie, 155, and 143. And the 143 doesn't cause cross resistance to dolutegravir, okay, whereas the other 2 do. And in patients who are naive to the integrase inhibitors just go straight to dolutegravir. We said it was the 263K, was previously most common, but being overtaken, I think, by the 118R or at some stage, and the 155H, low prevalence. If you see a patient with sort of these kind of mutations, 118R or 263K, you know they've only been on dolutegravir. If you're seeing a 143, or sorry, a 148 or 155, then most likely they were on before and then went on to dolutegravir. Okay, so to summarize, the mutations to antiretroviral developed at the target gene that cause cross-resistance, resistance to that drug and other drugs, what we call cross-resistance. And the longer they're on a failing regimen, the more mutations will develop and the more resistance the patients will have. Okay, so now we're going to talk about the Stanford database, which is an amazing, amazing, amazing tool, which has been developed by a person called Professor Bob Schaefer. And so I'm going to tell you about this. This is the algorithm that all the laboratories, or virtually all the laboratories, use to analyze their resistance. Okay, so I'll tell you a bit more about it. It's used by all the labs to analyze their resistance results. You can either input sequences, what the labs do, all right, where they just analyze them, throws all the sequences in and it will analyze for them, or you can put the actual mutations in, which is what we're going to be doing, right? We're going to be putting the mutations in. So why would you want to use the Stanford database? So if you're a laboratory, you need it for sure to analyze your data, but we're not laboratories. What do we need it for? So firstly, I had some very dodgy, not very, but occasionally, some dodgy results from the lab where it didn't make sense. Go and confirm, is it correct? Put it into Stanford database and see if it's correct or not. Okay, remember, things change with time, right? I had a patient in 2008 did the resistance testing. There was no darunavir in those days. I have no idea if darunavir works in that patient. So what I do, I took that patient's resistance mutations, put it into the Stanford database recently, okay, and got a thing. And now it would tell me if darunavir would work for that patient. So you can reanalyze old resistance results with new data and with new ARBs. Also, data changes all the time. Something which in the old days we said was caused high level resistance. Now maybe it only causes intermediate resistance. So there's new data coming out. So it's very good, especially if it's an oldish resistance test, then you want to reanalyze it. Sometimes patients have got more than one. I know Mervin's talking about patients, 4 or 5 resistance tests. So, if you just use the current resistance test, you're going to miss what was done previously, right? Because those mutations are there for life. So what you need to do is if you've got a patient who's got more than one resistance test, you take all the mutations from all the tests, put them onto the Stanford database, then reanalyze, and that gives you a proper composite assessment of that patient's true resistance. All right. Otherwise, it's pure guesswork, because if you're only looking at what they remember, resistance tests tends to only tell you about the regimen they're on at the moment. So it doesn't tell you about the first line or second line. So you've got to take those first line, second line mutations and analyze them together with the Stanford database. So there are very important reasons to use the Stanford database. Okay. The last one, as a learning experience, it's fantastic for us to learn about mutations and read and put mutations in, take mutations out, put them in, see what affects the mutations. Fantastic to do. Okay, I wouldn't do it in the bath. Okay, but other times when you relax and you want to play around and you want to practice, take a patient mutation, and say what would happen if they didn't have this mutation? Take the mutation away and see what happens. Okay, and also it's a lot of fun. So we're going to be doing for the last 2 reasons, but there are other very reasons why you would want to use a Stanford database. Right. So how do you access it? So I've given you the link, and that's probably the best way of doing it. But if you don't have the link, just Google Stanford DB. And the first one that comes up, you just click HIV DB program. So you Stanford DB, the first one comes up, you click on Stanford DB program, and it will take you straight into the database. And this is what it looks like. Those of you who already joined up, I'm sure you've seen there are 3 columns, right? There's reverse transcriptase, protease, and integrase. And you can either put your mutations in on top in the white rectangles, you can type them in, or if you're lazy, like me, you can use the drop-down menu. So I'm going to recommend that you always use the drop-down menu. Why? For 2 reasons. Number one, a lot less work. You don't have to type out M184V, just go to 184, click on it, find the V and click on it. Okay. Also, there are a lot of the mutations we're dealing with cause resistance, but there are also a lot of mutations that don't cause resistance, right? We call them polymorphisms. It's a mutation that doesn't cause resistance. Now, sometimes you can have a patient who's got 20 mutations, but only 2 of them are real mutations. The rest are polymorphisms. You'll type in all 20 mutations, take you 20 minutes, okay, to discover that you could have just typed in 2. So the ones in a drop-down menu, those are the important ones. All the rest you can literally ignore, okay? So if you choose the drop-down menus, will save you a lot of time because you'll only put in the important ones. You won't have to, type in ones that turn out to be unimportant or polymorphisms. Okay, so Eden, I'm not sure what you're asking about. Is there a relation between resistance and reinfection? You mean if the patient is, if someone doesn't have resistance and someone else reinfects them and they pass on resistance to them? Yes, but not all resistant mutations are transmitted. Okay, so someone's got resistant virus, and they may or may not pass it on to someone and reinfect somebody else. But certainly they can, potentially they can. And a very good reason why patients who've got HIV should be using condoms, even if they are with another patient with HIV, because they may pass on resistant mutations. I think that's what you're asking. Okay. All right. So this is it. So you should be able to access it now. You get the 3 columns, and I'll show you as we go how you type in the mutations. So you type in the mutations in the drop-down menu. When you're ready, you click on the bottom right. It's a bit small now, but you'll see where we do the actual one. Analyze button, and you analyze. That's it. Now, if you look closer next to the analyze button, I've blown up here. It says there, save input mutation in my browser for future use, with a little button next to it. Now that button, very proudly, I call the Leon button, because I actually asked Bob Schaefer to put it in, and he put it in, okay? And it's really for our purposes, but not just for teaching purposes, but there will be certain situations I'll explain to you. Normally, when you click on the back button, it will wipe out everything that you typed in. Sometimes you don't want to wipe out. Sometimes you want to add in another mutation. What would the effect be if we had this mutation? So then you click on this button, and that will keep what you've got. So when you click on the back button, it will still be maintained. So I'm very proud that Bob did put it in for me. I'll show you a situation later on where we actually would use that. Okay. Right. And then this is the kind of report that you're going to get. And you can see it's a bit small. Apologies for that. This is a typical report that you would get from the laboratory, right? You can see it's M1A4V, and it gives you the go to itracitabine, high-level resistance, lamivudine, high-level resistance, exactly like you would get. That generates a report just like you would get in the laboratory. Or from the laboratory, put that way. Right. How do we interpret it? So if it's high level or intermediate resistance, the drug won't work. If it's low level or susceptible, the drug will work, obviously, if the patient takes their medication. And this, maybe you should write this down or take a screenshot or photograph of this. It's very important. This is the mutation score. So how this algorithm works is they give a score to each mutation. And the computer just adds up the scores and then decides if it's resistant or not. Okay. So if it's a score above 60, that's high level resistance. 30 to 59, I'm working backwards, is intermediate resistance. 15 to 29, low level resistance. 10 to 14, potential low level resistance. 0, to 9, susceptible. And negative, below 0, that is hyper susceptible. That's where, remember we said BTC would make it hyper susceptible to AZT and D4T. So it would give it a score of -10. So right so now, it's hyper. What does hyper susceptible mean? It means if they've never been on that drug, it will work even more actively. But if they have been on it, it will reduce the score by a score of 10. So the AZT score is 60, which is high level resistance, to reduce it down by 10 to 50, which is intermediate resistance. So partially reversing resistance to the drug we're talking about. That's hyper susceptible. We'll see some examples of that as well. And this is what the mutation score looks like. You can see here's the mutation, one for V, and the drugs, and you can see that for BTC and FTC gives a score of 60, which we said 60 was high-level resistance. There we go, 60, high-level resistance. So you've got high-level resistance against 3TC and FTC. Backup, 15. What is 15? Low-level resistance. Okay, 15. In fact, they say that although they call the 184V low-level resistance, in the real world, in terms of practicalities, it doesn't actually make a major difference in terms of activity of a backup. So backup is really, although they call it low-level resistance, you can use it with a 184V. And then also, in addition, look at AZT and TDF, -10. What is minus? We said hypersusceptible. So it means it's more active if they've never been on those drugs, or if they've got resistance, will reduce the score by a score of 10, hypersusceptible. Okay, so that's your mutation scoring. They're also a very useful comment, okay, which the laboratory doesn't give you. It tells you about those mutations. Tells you what it is, if it's a polymorphic mutation or it's non-polymorphic. Remember, polymorphic is one that doesn't cause resistance. So non-polymorphic is one that actually causes resistance. It tells you all about those mutations. Very useful, the comments they have there. All right, and then when you finished, sorry, go back one. When you finished, you click on the back button, and that will wipe out what you've inputted up to then. So you can do the next one, unless you've clicked on the little button to say, don't wipe it out, in which case we'll keep it, and you can add in whatever else you want to add. Okay, so I hope you're all connected. I'm going to stop sharing there. I hope you're all connected to the Stanford database. If you are having problems, maybe just message or type into the chat to Dr. Mawela. Maybe he can try and help you if he can. If he can't, unfortunately, you'll have to just watch what I'm doing on the screen. My screen is frozen. Are you still there?
Yes, I'm here, Leon.
Thanks. Okay, I just want to try and unfreeze my screen.
Okay. Colleagues, I'm sharing the link again, specifically for the Stanford database. Yeah, and then so that you are not confused which one to click. Yeah. I've just shared. Thank you.
Okay. What are you seeing at the moment?
I'm seeing Dr. Leon.
Are you seeing me? Great. Okay. We're back in action. All right. So now I'm going to also go on to that Stanford database. All right. I'm going to quickly find the link.
Okay.
On this one here, this will help me.
Are you ready, colleagues? Are you ready? Are you ready?
Is everybody ready? Okay.
Yeah.
Let's get to Zoom, and we're just going to go onto the Stanford database. Computer a little bit slow. There we go. Okay, I've got it saved there. All right, so we've got the 3 columns. We all got the 3 columns? Fantastic. I think somebody's unmuted. All right, so I'm going to ask some questions, and then we are going to answer them by means of some of them just on your own and some of them with a poll. Okay. Right, so you can see the 3 columns. So we're going to practice. We're going to start off to make it nice and easy with just 1 mutation at a time. Obviously, in the real life world, we don't need you to get 1 mutation, but just to make it easier. So the first mutation in reverse transcriptase, that's in the left-hand column. All right. And you have to input M184V or 184V. So what do? You go to 184. You see where my arrow is. Click on it. There it gives you a choice of I, V, or a star. You choose the V. And if you look on top, the white rectangle 184V is there already. And then you go to the Analyze button and click bottom right, Analyze, and you should get a report. Okay, I hope you've all seen something like this. If not, ask Dr. Lesejo. Maybe he can try and help you if it's straightforward. Okay, so you can see the report. There's part-time mutations, 184V, non-nucleosides, none, other mutations, none. Okay, are you all good? I see 1 thumb.
We are good. We are good.
We're good. We're good. Okay, so now the question I want to ask, what effect does this mutation have on 3TC and FTC? Fantastic. So look at 3TC, lamivudine, and you see there, high level resistance. Okay, FTC, high level resistance. All right. What about a Backup? Where's the Backup there? Lower level resistance. Okay. Tenofovir and AZT, susceptible. Right, the next question is you've got to look at the mutation score. So scroll down to see the mutation score, like you're seeing on the screen now. And what effect does it have on the mutation score of 3TC? So have a look at 3TC. You can see a score of 60. Can you all see that? Right? A high level resistance. A back of a 15. Low level resistance. But look at AZT, minus 10. Hyper susceptible. Tenofovir, hyper susceptible. Okay, meaning that if it's never been on tenofovir, then it will work even better. But if they haven't got some resistance to tenofovir, it will reduce it by a score of 10. All right, are we all good? Great. Okay, now we're going to click the back button. Do the next one. The back button, here's the screen. Okay, and this mutation now, also reverse transcriptase, is K65R, or just 65R. You've got to find the 65. You've got to find 65. Click on it. Drop down to define the R. Click on it. And then you're going to go to the bottom right to analyze and click on analyze. Okay, the questions on this. What effect does this mutation have on 3TC? See, low level resistance. FTC, low level resistance, they always go together. All right. Tenofovir, intermediate resistance. And AZT, susceptible. Okay, let's go to the mutation score below. What effect does this have? You can see for tenofovir 45, which is intermediate, backup 45, intermediate. Okay, FTC 15 and FTC 15 low level, and AZT, can you see? Minus 10. What's that? Hyper susceptible. So a patient who's got K65R, for AZT, it's hyper susceptible. And that's why in the old days, we always used to use AZT second line after tenofovir because we knew it was hyper susceptible. The Nadia study showed us it wasn't necessary to do that, but that was the motivation behind it, to go AZT after tenofovir, because the K65R would make the virus hyper susceptible to AZT. Okay. Now my next question is going to be a poll. We've got to see if we can find the poll. There's the poll. The use of which drugs leads to this K65R mutation? Use of which drugs leads to this K65R mutation? And it's multiple choice.
Super.
Great. Okay. Right. Let's end the poll there and share it with you. So, very good. So 67% said tenofovir. Excellent. Tenofovir. 52 said a backup. Yes, a backup can do it. Much less in our situation, in our setting, but it certainly can do. All right. And then PTSD, 24%. Okay, so the real answers is going to be obviously tenofovir, DDI, Abacavir, and D4T. Well, put D4D there. Okay. Anyway, so we don't use D4T anymore. That's probably why I didn't put it. Okay. Okay. Or maybe it just fell off somewhere. So the main ones, our setting is tenofovir and Abacavir, but obviously DDI, which you don't use anymore, and D4T, which you don't use anymore, can also do. Okay, great. Fantastic. All right, and the next question I think has also got a poll in it. Okay, well, the use of which drug prevents the development of this mutation? Is it Abacavir, BTC, DI, tenofovir, or AZT? Which drug prevents, and I've got to say, which drug and resistance to that drug causes, prevents the K65R development? And I see we're preaching to the converted today. Well, things are changing. The converted answered quickly, and then everybody else started answering. And
The
those answers were
competition. Is it two options? Makes
yeah.
Yeah.
All right, I think let's end it there. Okay, I'll share my results. So yeah, you're right. 55% usually AZT. AZT or TAMS prevents K65R developing. So the patient's been on AZT before, they've got TAMS, they've got less chance of K65R developing. But remember, if you have enough TAMS, especially with at 41 and 215, you can still get resistance to tenofovir. So it won't protect from resistance to tenofovir, but it will prevent you from getting K65R. Okay, great, well done. Let's continue. All righty. Let's do the next one. Let's on the back button, clear the screen. Also only one mutation. It's in the reverse transcriptase, and it's A103N or 103N. So find 103, 103, drop down to find the N, quite a few options, and then go to analyze and analyze. So now you can see, unlike the previous ones, which were NRTI mutations, this is a non-nucleoside. Okay, it's not affecting the NRTIs, but affecting the non-nucleosides. All right, what effect does it have on the favrins and the nevirapine? Well, you can see favrins high level, nevirapine high level, but you can see it spares etravirine and rilpivirine, spares the second generation non-nucleosides. This patient's only been on nevirapine in the past. How come it's resistant to favrins as well? Well, you all know that answer. There is cross resistance. Okay, great. Let's do the next one. Button, clear the screen. And now we are going to be doing a mutation, not in a reverse transcriptase, not in protease, but in integrase. All right, and this mutation is the R263K, or just 263K. So find 263 right at the bottom of integrase in the right-hand column. Click on that and find the K. There's only one option of K, and then analyze 263K. So now you can see in integrase, 263 is a major mutation. All right. What effect does it have on dolutegravir? On dolutegravir, you can see intermediate resistance to dolutegravir. Cabotegravir, which is our injectable, high level resistance. Okay. Raltegravir, interestingly enough, low level resistance. But we don't use raltegravir anymore. It's a 263K, which is the classic in vitro resistant mutation against dolutegravir, causes intermediate resistance to dolutegravir. Right, now, looking at in the comments, was my next question is, if dolutegravir is used, how should it be dosed? Dolutegravir resistance, if BTG is used, it should be administered twice daily. So remember, got a patient who's got integrase resistance, you give the dolutegravir 50 milligrams twice a day. Okay, and this is telling you this fantastic algorithm is telling you this is the case. You've got resistance, give it twice a day. Okay, and you can see looking at the scores, you can see dolutegravir is a score of 30, which is intermediate resistance. Cabotegravir 60, right? What did we say Cabo was? High level. You can see 60 is high level resistance. Okay, so that's our injectables. But GTG only 30, which is intermediate. Okay. Okay, let's go on. Just want to have a look at my vocal cords. Okay, so up to now, we've been doing one mutation at a time just to get hang of it, right? But obviously in the real world, there's usually more than one mutation. Let's click on the back button. I have already. If you haven't, just click on the back button. Okay, and now we're going to have a real life case with 3 mutations, all in reverse transcriptase. So in the first column, first one is 65R or K65R. So find 65, up, down, find the R. The next one is 184V, 184V. And the next one is K103N or just 103N. Find 103, up, down, onto N. And then you analyze. Bottom right, we analyze. Right. And so you can see here that this patient's got 2 NRTI mutations and 1 non-nucleoside mutation. All right. And the NRTIs, what is it doing? It's causing resistance against tenofovir, intermediate resistance, high level, TTC and FTC. The back of it's high level as well. And the non-nucleoside mutation 103N is causing efavirenz and nevirapine high level resistance and susceptible to doravirine, which is a new one which we don't have here in South Africa yet, efavirenz oral pill. If we drop down to the mutation score, you can see.
Oh, so
you can
I had
see
an aha
here
moment.
65R is causing resistance against tenofovir. 35, right? Intermediate resistance. Ezity is going to get a hypersusceptible for the K65R and hypersusceptible for the 184V. So your AZT score is -20. Okay. This patient would be failing what regimen would you imagine? Old, what? K65R, tenofovir, TTC is 184V, and 103N is non-nucleoside. So this is classic what we used to see in patients failing TEE. Tenofovir, intracytidine, or 3TC, similar, and then non-nucleoside efavirenz. Okay. That's what we used to see in the old days. Never used to do resistance testing in that situation because we predicted what would happen. It wasn't necessary to do resistance testing. Okay. Click on the back button. And now, we cleared the screens. You've got a 7-year-old patient, started on D4T, 3TC, and efavirenz at the age of 5. And they did this resistance testing that I'm going to show you now. Okay. So she was on D4T, 3TC, and efavirenz. Let's give the mutations. First in reverse transcriptase. Now remember, this is a real life case. There's lots of mutations. The first one is 67N. 67N. The next one, 70R. 70R. The next one is 101E. So 101 and E. That's the first one is E. The next one is 181C. So find 181C. There it is, 181C. Next one is 184V and 184V. Now, old friend. 215F. 215F. Where's F? There it is. 219Q. 219Q. There. That's reverse transcriptase. Now we're going to do protease. Protease. First one is going to be 15V. The 15V, oh, look, it's not here. Could type it in on top, but it's not going to be of significance. But I'm just to show you, I'm going to put in 15V, and we'll check it later and see what happens to it. Okay? It's not here, so we can leave it out. You don't have to type it in. If it's not in the drop-down menu, you can leave it out. So 15V. Next one is 19I. Not there, we leave it out. Isn't this fun? 36I is there, so 36I. Good. Next one is 69K. 69K. Sounds like an auction here. 69K is not there, so we leave it out. 89M, that is there. 89M. Next one is 93L. 93L, last one, 93L. Okay, and then we're going to analyze. Bottom right, analyze. Right, so what do we have? Let's look at the protease inhibitors. No majors, no accessories, and others. What does it do to the virus? Nothing, all susceptible. Right? What do we call that? Mutations that don't cause resistance. Remember I mentioned earlier? We call them? Oh, I've got a poll for it. Let's see what the poll says. Let's do the poll. Why does this patient have protease? Oh, I've given you the answer already. Sorry. Why does this patient have protease mutations? You all got it right. Well done. Okay. Is it polymorphisms, resistance to dolutegravir, polymorphisms, or polymorphisms? Okay, great. So I gave it away, but that's fine. So, see, some people are typing in some of the others. So this patient's got mutations that don't cause resistance. Okay, I'm going to end the poll there. And you're quite correct. Those are called polymorphisms. A mutation that doesn't cause resistance is called a polymorphism. Now, very often what polymorphisms are the difference between our virus, which is in South Africa, which is subtype C, and what they have in the rest of the world, subtype B. So in subtype, so there are little minor differences. So if this patient has subtype B and they have these mutations, it might be significant for them, okay? But for our patients, it's not significant at all, and it's just normally occurring for our patients. So these are polymorphisms, which are often so common for our viruses, but they're different to subtype B, and that's why it picks it up as a mutation. Okay, so that's the protease inhibitor. So this patient wasn't on a protease inhibitor. We weren't expecting resistance. So these mutations are just telling us that the polymorphisms, there's no resistance. So looking at the reverse transcriptase, you can see, wow, look at this. High level resistance to everything except half of which is intermediate resistance. Okay. And the question I've got here in front of me says, and it's a poll, how many thymidine analog mutations are there? How many TAMs are there in this patient? Have a look, and I'm going to put the poll up. How many TAMs? You can see thymidine analogs, the AZT, okay, also D4T. Now, if you want to have D4T, I'm not going to put it in now, but you can plug it in at the beginning. I can show you. D4T resistance as well. Okay, you can see it's cross resistance to the entire class of the NRTIs. Obviously, 1A4V is providing resistance against PTC. If you have a look here, PTC is a little bit of resistance from the TAMs. The most of the resistance comes from 1A4V there. Okay, whereas the AZT, all the TAMs just add up to give you this massive score of 125. Okay, so this is the poll. How many TAMs we have? Go back. How many TAMs are there? 1, 2, 3, 4, 5, or 6? If you don't know, you can guess. Yeah, I'll read out the positions and you can tell me. So TAMs are position 41, the check if it's there or not, 67, 70, 2110, 215, and 219. So how many TAMs are there in this patient? Do they have all 6, 5, 4, 3, 2, or 1?
I got it.
You got it. Okay. No one wants to answer you, okay? Right, so there are, let's go through. 41, is it here? No. Okay.
No.
67, is it here? Yes.
Yeah.
So there's 1. 70, yes,
Yeah.
this patient, so it's 2.
Uh-huh.
Okay. 210, no, still 2. 215, yes, so it's 3. 219 is 4. So the answer is 4. The answer is 4. So there are 4 TAMs here. Okay, we're just gonna end the poll. Nobody answered. No problem. Okay, so there are 4 TAMs, and obviously the other 2 TAMs are position 41 and 210. Great. That's the TAMs, and now we are going to do another patient. This is a patient who is failing a AZT3 lopinavir, our old second-line regimen. Previous history unknown. We don't know what they were on before. Okay. Let's do the mutations. Reverse transcriptase, the first column, 41L. 41L is there. 44G. Now look, 44 is there, but G is not there. Can you see? Only A and D. So you could just leave it out. If it's not there, leave it out. But because this is supposed to be teaching you something, let's show you how you could put it if you wanted to. You see the little star there, asterisk? Click on the star, and you can see it opens up a window on top, and then you can put the G in that window. But you don't have to, because if it's not there, it's not important. Put the G in, and okay, and you can see on top, 34G appears there on top. Next one is 67N, another TAM. 67N. 70R, another TAM. 70R. We're all good. I can see the thumbs, okay? 98G. 98G. Good. 100F. 100F. Not there. Star, type the F in on top, but you don't have to. It's not important. 100F was the last one. 215I. 215I. Scroll down to get there. 215I is there. 219Q. 27L. 238Q. It's not there. I'm going to leave it out this time. Now, protease mutations. There's 46I, 146, 46I, 54V, 82A, and 90M. 90M. Okay. All right. Now, before you analyze, I want you to click on this button, Save Implementations in my browser for future use. Okay. Right. So this patient is failing AZG3C lopinavir. You've clicked on the little button and now analyze. Okay, so let's have a look. Protease inhibitors, what have we got? 4 major PIs, no accessories, and it's got high level resistance against atazanavir, high level resistance against lopinavir, but susceptible to darunavir. So in today's, with that algorithm I told you about 2 talks ago, you could actually, this patient in third line could get TLD, right? We didn't know those in those days. Okay, that's the protease. We have got high level resistance against atazanavir and lopinavir. You can see you've got a score 0 for darunavir and a score of 110 and 100 for the other 2. Looking at the reverse transcriptase, you've got a whole lot of TAMs, so you've got high level to AZT, D for T will be the same. Immediate to alpha, you also got 2 non-nucleoside mutations you're seeing over there. Okay. So the page is on AZT, 3TC, and lopinavir. Now, which question, poll number 1, which mutation which should be there is not? Questions on AZT, 3TC, lopinavir. Which mutation is missing? Have a look there. I'm going to put up the polls. Which mutation which should be there is missing? Is it the K65R, the 184V, 263K, 118R, or 103N? This is a patient who's on AZT, 3TC, and lopinavir. Which mutation which should be there is missing? Okay, it's in the poll. Here are the results. All right, and you can see everybody said, or most people, 47 said 184V. Quite correct. Remember, the patient's on AZT, 3TC, and lopinavir. 3TC mutation is 184V. Can you see 184V there? No, it's not there. It's the first mutation to come. So this patient has to have it. If they are failing a regimen and are on 3TC, that mutation has to be there. So if it's not there, it means they're not taking their 3TC. Remember, it's a slow car, 10 kilometers down the road. As soon as you stop your 3TC, it disappears. So if you don't see the 184V, means this patient has stopped their 3TC. They might still be taking the other drugs, okay? The PIs, the AZT is usually tied together with the 3TC, so they've probably stopped the AZT. And maybe in a short period of time, they've stopped it. Okay. Right, so 184V is not there. Patients should have it. They've got it. It's archived in the body. We're not seeing it. Okay, next question. Also a poll. This patient has got non-nucleoside resistance. Look at that. High level to doravirine, okay. High level to nevirapine, intermediate to rilpivirine, intermediate to etravirine. Patient is on what regimen? Is it T3G lopinavir? Where does the non-nucleoside resistance come from? That's our next poll. Where does the non-nucleoside resistance come from? Multiple choice. From a previous non-nucleoside regimen? From PMTCT, if it's a woman? From transmitted resistance? Or from cross-resistance from the PI?
I only know the one that's not correct.
And some people are still ticking on it.
Yeah. And it's
Yeah.
competing with.
But that's why we're doing this, so we can learn. We do it so we
Yeah.
can learn.
Yeah.
Okay. All right, good. Let's end the poll there. All right. So, previous non-nucleoside regimen, for sure, the patient, we don't know the history, could have been on a non-nucleoside. This was their second-line regimen. Could be someone in the old days who went on to nevirapine, or a child who had nevirapine for PMTCT, definitely. So the second one is correct as well. Transmitted resistance, yes. Somebody was on a non-nucleoside regimen, passed their mutations onto this person who's now got resistance to the non-nucleoside. The only one which is not correct is the last one, resistance for the PR resistance. Remember, cross resistance never goes across classes. So you can't get cross resistance to a non-nucleoside from a PI. It has to be from a non-nucleoside. Okay. So the last one is not correct. Okay. The PIs can't give you cross resistance to another class, only to the PIs. Okay, great. Very good. What would be an appropriate regimen for this patient? So we said, based on a new algorithm, we said this patient could get TLD in third line. So third line patient, they can get TLD because the darunavir is susceptible, which means we've got a good future darunavir regimen which we can use. So let's put them on TLD, even though this intermittent resistance to tenofovir doesn't work. We can get a nice once daily darunavir regimen. Okay, so that's what our new algorithm would say. This patient can get TLD today. Obviously, in those days, the patient didn't get TLD, but things changed, fortunately, for the better. Okay, good. Let us click on the back button and take off that save the input mutations. And we'll do our last case. 80-year-old has been on AZD3TC for 2 years after failing an AZD3TC lopinavir regimen previously. Viral load is 7,000. Failing the old second line AZD3TC and dolutegravir. Okay, so first mutation, reverse transcriptase, one attempt, 67N. 67N. Okay, 70R, another TAM. Patient is failing AZD3TC and dolutegravir. Makes sense to get TAMs. 70R. Okay, 184V. Found the patient does have 184V or 3TC, 184V. Okay, next one is 103N, our non-nucleoside mutation that persists for a long time because it travels at 110 km an hour. And 225H. 225H. Okay, and now patient, the PI is what? 82A. In the middle column, PI 82A. All right, next one is I54IV. So find 54. There's V. But if you want to put in I, it's not important, but the mixture, right? You want to put in I as well. Click on the star and on the I as well. And then you'll see it says I54V and I, right? So that's your mixture. 33F, still in the PIs, 33F. 33F. And 10F. 10F. Okay, and now the last column, patients on AZD and dolutegravir, the integrase inhibitors, there's 36K. So 36K is not there, we can leave it out. 118R. 118R. Okay, and 66A. 66A. Okay, and now we can analyze. Patients failing AZD3TC and dolutegravir of the PI regimen. So the PIs, you can see, you've got two mutations, two major mutations, two accessories. Potential low-level resistance to darunavir. The other two is high and intermediate. And then reverse transcriptase, you can see the settle to tenofovir, low level, a back of a intermediate AZT, and high level against the other two. You've got your non-nucleoside mutations there as well. Okay, and integrase, going down to the bottom, you can see you have got intermediate resistance to bictegravir and high level to all the rest. And that's it, 118R. If you go to the scoring system, you can see 118R gives you dolutegravir 60. Score of high level resistance. So that one mutation causes a high level resistance to dolutegravir. And this is our commonest mutation that we're starting to see now. Okay. So the questions: which entities are still active? So you can see none really, right? We said active is below intermediate. So none are active, right? This patient's got intermediate or high level resistance to all the entities. PIs are still active. Okay. So I haven't got it as a poll, but going to the PIs, we can see it says here that Brunova's potential low level resistance, that would be active. My next question is, are you sure? Are you sure? Remember, is a patient on a PI? No. What we're seeing now from the previous regimen, some of those mutations may have disappeared. So what we're seeing here tells us there's definitely PI resistance, but is this how severe it is? No, it could be even more severe because some mutations may have disappeared. Okay. And then which regimen should the patient receive? Well, we've got resistance against, according to the algorithm, you've got resistance against integrase inhibitors, dolutegravir high level resistance. So you would then want to use 2 NRTIs. So you use tenofovir and FTC plus ritonavir once daily. It may not work because the patient's not on a PI at the moment, right? So you may be missing some mutations. So you need to watch very carefully. And if they're not suppressing, repeat the resistance testing to then see, do we need to do something else for that patient. Okay, I think that's a lot, Lesecha. I hope people had fun tonight. I think there weren't too many
I've
questions.
had a lot of fun. I remember my first day in the workshop in person. I was like, oh my God, what's going on here? But I had to attend it again, read. And today,
Right.
maybe my 15th session, and I can tell
Right.
you, I have learned something. The R263,
Yes.
R263K, and the fact
Yes.
that DPD should be BD. I think I've missed it previously. Today I got it.
Right.
So, colleagues, there's
Okay.
always something to learn. There's always
Absolutely.
something to learn.
And also what Lesecha is saying is that it may be daunting on the first time. You've got to keep going. This is
Yeah.
recorded. Go back and do it. Take,
Yes.
take these things and play around with the mutations. Take some of your patients from the clinic. Take their resistance tests, type them in and have a look at them and see. Play around, take out the 184V, put it back, see what it does. So very, very important then. Okay.
Super, super.
Right.
Thanks.
Okay. So there wasn't much questions. The one said, would we recommend resistance testing for pregnant women themselves diagnosed positive as children? They're fully suppressed and intend to breast. So they're fully suppressed. You don't need to do resistance testing because you're not expecting them to pass it on. And remember, you can't do resistance testing unless the viral load is above 1,000. In some labs, you can go down to 400. Okay, so you can't do the resistance testing if they're suppressed. But if they're failing, yeah, you would definitely want to. Obviously, it depends what regimen they're on, but certainly those patients do qualify. Sorry, I've just got a blackout here. So if I look a bit funny, you know why. So that's to answer that. If they're suppressed, you can't do resistance testing. The viral load must be 1,000 in most labs. Some, NHLS and the private labs would, if you ask them the favor, they'll probably manage with the viral load above 400. In which case can we use dolutegravir and ritonavir? I think in very few cases. I mean, if the patient has got so much resistance that you need to use both a dolutegravir plus a PI, you would most likely be using darunavir as your PI. The one case maybe where you could possibly do that, but you could use atazanavir ritonavir as well with it. So you could have a once-daily regimen would be, for example, if the patient gets a very rare side effect of 3TC and FTC and a pure red cell aplasia and anemia, and you can't use 3TC, then you could use maybe dolutegravir and a PI. That'd be one of the things you could do in that situation, but it wouldn't be very common. In Mozambique, they use alpha 3TC for PrEP. Please comment on the significance of PrEP as resistance to drugs for efficiency of PrEP. So it's a very good question. So would PrEP work if you're going to have a lot of resistance, especially to 3TC? So not for that, I think we have less resistance. But remember, so if the patient is failing their drug, and they're taking their drugs, they've got resistance, you may have circulating resistance to tenofovir, and yes, it could possibly cause PrEP not to work. But we do know that in the real world setting that this regimen works pretty well. So in the real world setting, as long as people are taking their PrEP, it does work. So I'm not that worried about using PrEP because of how much resistance we have. It does seem to be effective. So I'm not too worried about it. With time, we're going to get resistance against the non-nucleosides we've got already, and also the integrase inhibitors, and then our injectables, which is cabotegravir and rilpivirine, may not work. And then we're worried about using cabotegravir as PrEP as well, but I don't think we have any data on that. And at the moment, the resistance is very, very low. So I hear your question, but I think in the studies that have done in the real world have not shown that this to be a major problem at this point in time. But obviously, we need to keep. That's why we're doing surveillance all the time to monitor what's going on out there. Okay, Anonymous has got a 29-year-old female who's 24 weeks pregnant, on T for 2 years. Viral load is 169,000, CD4 184, creatinine is normal. Okay, so luckily she's fairly early on in the pregnancy. So we are seeing more and more polycyclic resistance in patients who are pregnant. She didn't say whether she's a TLD1 or TLD2. Okay, because that's the important question you want to ask. Because remember, TLD1, virtually no resistance. If they've never failed a regimen before tenofovir, before dolutegravir, then TLD1, that's TLD1. And then in our guidelines, we don't do resistance testing on those patients. If it's TLD2, this patient would qualify if they were adherent. But we are seeing more and more resistance in pregnant patients. And I am starting to think that pregnancy is a risk factor for dolutegravir resistance. So I would certainly do resistance testing in this patient, even if she's TLD1. Strictly speaking, the guidelines say no, you'd have to ask an expert. But if you asked me as an expert, I would say do it, but not when she's non-adherent. You need to get adherent. So you need to take her treatment for a month and then do resistance testing in a month's time. Okay. And we are seeing more resistance in pregnant women. And of course, pregnancy is a time bomb. It's not like someone who's not pregnant. You can try it for another 3 months, see if that's suppressed. Pregnancy, you don't have that luxury. So you want to act. And it's one of the situations where I think we do go, the experts may push the rules a bit and say, even though TLD1, we can't take a chance here. We don't want a baby with resistance. And so, or we don't want a positive baby if she's resistant, right? And so we would say that. So you need to individualize it, discuss with an expert. I'll be very tempted to do resistance testing, but getting her to be adherent first for a month and then do resistance testing. But I'd need to hear the whole story. So contact me and I can help you with that patient. But my feeling would be probably to push towards resistance testing sooner rather than later. Okay, and then I think the last one, 59-year-old TLD1, switched from TE with the viral load suppressed. So this patient would then be TLD1, quite correct. Now I've been referred to 2 detectable viral loads in the last 2 with low level viremia. What's good adherence, attends all clinic visits, question investigation PTB, okay, and they follow up an LL ETZ from last year. What else did you investigate at this stage? So this is a common scenario. We are seeing low level viremia, and I think you need to look at how low it is. If it's below 200, I think that's fairly okay, and people don't get too anxious about below 200. Above 200, some people get more active, but bottom line, what it's telling us is that there's a chance the regimen will fail. So what I would do is do viral load testing more frequently. I think, yes, to look for opportunistic infections, you possibly could do that. Also remember with dolutegravir, you've got all those interactions, especially the over-counter drugs like antacids, calcium, magnesium, zinc. All of those, can interfere with the absorption. Has the patient been on TB treatment? Not yet, but maybe you're going to put them on that might make it worse. But get that kind of history, and if you have got that kind of history, then let them stop the antacids. They'll take the iron at a different time of day, so as to avoid the problem with the inhibiting the absorption. But otherwise, especially if it's below 200, I would just watch them and do viral loads more frequently. But I wouldn't do more than what you do. Okay, well, my lights have come back so you can see me better now. Okay, I think that's all the questions
Two more
to deal
from
with.
me, Leon. Two more from me. Just
Oh
want to
no. But
in,
Lesego, you always have the worst questions, the most difficult ones. Okay,
yeah,
all
no,
right.
it's on a lighter note, Leon. Just to check, 3TC monotherapy in the modern era, is there still a role for that, or
That's a
it's
good
gone?
question. No, it hasn't gone, but very rarely. So 3TC is
Yeah.
something that we use. Remember that we said that mutation 1F4V weakens the virus and it's keeps the weakened virus there. When you take 3TC away, the wild type will come back and the viral will go back up again. Okay,
Yeah.
so it keeps the weakened virus there, and we use it in the old days, especially in pediatrics, to when we didn't have choices, we didn't have any other drugs available, we couldn't resolve adherence issues. We used that as a way of keeping the patient stable until such time as we had new drugs or we had new adherence. It's gone out of fashion because we've got better drugs, better formulations, fantastic pediatric formulations. So it's not necessary to use now. But I must say, I think I've got one patient on it with a patient with intractable adherence issues. Okay, she's actually
Mm.
requested to go back onto treatment now, so we're going to put her onto full treatment. And she did very well. I think she's CD4 was 900 on 3TC
Mm.
monotherapy. So it works great, but there's just no need for it anymore because we've got other better regimens. But in the old days when we were limited, it was something that was very useful.
Super,
Okay.
super. And then in Gauteng, for example, we have these pilot sites with the cabotegravir injection for PrEP. Should we see a patient who then seroconverts whilst maybe on the on the long-acting drug, or even, I don't know,
Yes.
with how do we approach those patients?
So I think those patients definitely would need resistance testing done. Also
Okay.
remember, I don't know what they're doing in the trials, but certainly from the trials overseas, the cabotegravir does interfere with the testing, and they actually ideally should be tested with a PCR or a
Mhm.
viral load rather than doing ELISA. But I don't
Or
know
in
what the
terms of
trials are.
diagnosis, in terms of
Yeah,
HIV
yeah,
diagnosis.
it
Oh.
can be very problematic in those patients. Um,
Mm.
so uh, I don't know what they're doing. Obviously, the trials will know what they're doing.
Mm. All
Yeah,
right.
yeah. Okay, so then a couple of new questions. Okay, point on compensating mutations. So remember we said last time that if a patient gets resistance,
Mm.
the virus is weakened generally, okay, not always, but mostly weakened. Now, if you keep them the same training regimen, you will often get more and more mutations developing. And some of those are what we call compensatory mutations, which strengthen up the virus. So now instead of replicating slowly,
Mm.
now replicates much more rapidly. And the viral load will then go up. Okay, so you can have a high viral load in a patient with a lot of, especially PR resistance, because they've developed compensatory mutations which strengthen up the weakened virus and allow it to replicate more rapidly. I hope that answers your question. Will the presentation be available? Yes.
Mm.
Um, is the web page actually sending data to the Stanford database, or is it running in your browser? I'm sorry, I don't know the answer to that. You know the answer? I'm not a computer person.
Yeah, just one small, because I see Dolly posted this twice earlier and Dolly's asking about a patient who experiences abacavir hypersensitivity and later they are failing a regimen. Should they expect? So remember, they had hypersensitivity to a
Right,
stopped, but 2 years down the line, the patient is failing some other regimen. Should
right.
they expect a mutation L74V? I think it's at 20. On the chat.
Where's that? Where's that question? Is it in the chat?
On the chat, not in the, yeah, like 8 minutes past
Oh, so I
eight.
didn't see it.
Yeah,
Okay.
sorry.
Yeah.
Yeah.
So look, so the important thing about that patient, remember, once you've experienced a 100% rejection, even though most of them are probably not real 100% reactions, you can't give them back again. They don't necessarily have resistance. So you won't necessarily find that mutation. And also, remember, if they had the mutation a long time ago, it might be archived by now. If they're not on a BACAVA, you won't see the mutation. So, you know, yeah, you may not see that mutation at all. And it's got no significance or relevance to the hypersensitivity reaction, which is hypersensitivity reaction is an allergy to a BACAVA, not a resistance to a BACAVA.
Okay.
Okay,
Super.
any other
Super.
questions?
No. I think from my side, there was just an interesting comment from Peter saying your presentation made him go back to his table on codons. You remember the biochemistry class
Yes,
that some of us
yeah,
don't?
yeah.
I dodged that class. Yeah. So yeah,
Yeah.
but lots of positive feedback, Leon, from the attendees. So just to say that
Great.
we will share the recording. I will ask permission from Leon to also share the notes. And I'm hoping that you will then practice from that. I saw some people were saying, can we also get the case studies to practice? Yeah, I don't think it's a, I don't know. I'll talk to Leon, but I don't foresee a
I don't
problem.
see the problem.
Yeah,
Yeah, I
I
don't see the problem.
don't see
Somebody was
problem.
asking for the TAM slide. I want to see if I can find it quickly for you.
Oh
Because I must put
yes,
up, they want to take a screenshot of the TAM slide.
always sound more. No, I think you have passed because you're already at
I passed it.
okay. Yeah, there we go.
TAMS,
Why
there we go.
Thames, yeah.
Just put it onto.
Yeah, colleagues, just to officially appreciate you for staying until this time. It's actually encouraging us that we should keep coming back here, and provide you with a very great educational experience. Like I've said, for some people it's overwhelming, but you are not alone. My first workshop was, yeah, like what's going on. So replay the replay as many times as you can. And when you start to see your real patients and getting the results from the lab, it should start to make a little bit more sense. But also note that you are not alone. Dr. Leon is always available. There's also the hotline. I don't know, Leon, if today you have your hotline linked.
Oh,
Yeah,
probably there somewhere. It's at the end. Let me go to the end. I hope it will be
yeah,
at the
so
end.
that people can take a snapshot of that. So for advice, for assistance, depending on the province where you are operating, like KZN, there might be a local helpline. There's also a national helpline. But please take a snapshot of this particular slide. But we will also share it with the notes from there. Yeah, Dr. Leon, as always, this was a superbly great one. I always listen to your talks, and for me, there's always something to learn. Colleagues, also join our community there. I've shared a link on the on the chat where you can ask questions and we can try and help you as well. We are building an online community. So yeah, join, just click the link, join in. If you are a member, you're already in the community, just log in and we take it from there. Colleagues, may I wish you a great night. Leon, your closing remarks?
My
And we
closing
close.
remarks. Two remarks quickly. So
Yes.
firstly, as the Seth said, is that it's often very daunting. It's like learning a new language, right? You suddenly,
Yeah.
so there will be people out there who are confused. What I suggest you do is go back and listen again, and play on the database. Play with the
Mm,
mutations. Okay, there are only
mm,
5 or 6 mutations that you need to know. Really, I mean, that's not a lot,
mm.
and that will help. And remember, our next talk, if I'm not mistaken, is going to be second and third line regimens in the DOH. And we'll talk a bit
So,
about private as well. But after all what we've learned now, what do we do to patients failing a first line? What do we do second line? We will bring in obviously the third, not in too much detail, the third line algorithm that we spoke about, also speaking about second line regimens as well, and also a bit of the science behind that. Some fantastic studies which have molded why we're
mm,
doing what we're doing.
yeah.
And thank you to everybody, and to thank our sponsors, AbbVie, to thank him so much for sponsoring
Yes.
this. We really appreciate it.
Superb. Colleagues, I also want to appreciate the colleagues I work with every day. Dr. Nomcebo, I saw you, Mr. Ngwenya Temba, Dr. Madonsela Nombuso Gauteng, Technical Clinical Manager. I hope we have something to share with our clinicians going forward. May I wish everyone a good night with your families. Bye.
And just to thank Dr. Lesejo for all that he does.
Thanks, Leon.
All the best. Good night, everybody.